who have connected here to attend this webinar. At the outset, I would like to welcome you all for this webinar, which is organized by the Department of Oral and Maxillofacial Pathology and in association with the Institutional Ethical Committee, Institutional Innovations Council from Tirthanka Mahavir University. This webinar is being organized to celebrate the 3rd National Oral Pathologist Day, the birth centenary of first oral pathologist, Dr. H.M. Dolokia, sir. Before we begin, I would like to ask our principal, sir, to say a few words to welcome our guest of the day. Over to you, sir, principal, sir.
Very good morning. Very good morning to all of you. I hope I am audible to all of you.
Yes, sir, you are audible.
Yeah. So, Dr. Anand,
Namaste, sir.
you are most welcome on this platform, and we are really very happy to host you for this fabulous session, forthcoming fabulous session of your webinar.
Thank you, sir.
And it was really great, and this meeting which Dr. Meghanand could arrange with you. So I would like to it would have been wonderful if we could invite you in person over here.
Surely, sir. This time when I'm in India, I'll definitely make it.
So anyhow, so hope to learn lots from you, and I'm sure all these participants are going to gain tremendous knowledge. And secondly, very more, rather I should say, congratulations to all of you on your Oral Pathology Day, and I wish you all the very best in all the future endeavors. Thank you. Thank you very much.
Thank you for giving me an opportunity also, sir. It was very kind of you, and I'm very obliged for that.
Thank you. Thank you.
Thank you, sir. Before we begin, with great joy, I would like to introduce our speaker of the day, who is going to speak about odontogenic tumors, recent trends. We have with us Dr. Anand S. Teginmani. Dr. Anand is my PG batchmate and dear friend from past 20 years. He has finished BDS and MDS from PMNM Dental College, Bagalkot, which is in Karnataka. He is the first oral pathologist to be awarded a PhD from Rajiv Gandhi University of Health Science, Karnataka in 2014. And he also cleared a fellowship exam from IOMP the same year. He has more than 50 publications and has won Best Research Paper Presentation in the IOMP National Conference. He has also contributed 3 textbooks, including the McDonald and the Avery's Dentistry for the Child and Adolescent in 2019. He has also been the Vice President of IUMP for 2 successive years in 2013 and 14. Currently, Dr. Anand is working as an Associate Professor in Segi University, Malaysia since 2015. We are really sanctified to have such an eminent personality today with us. Thank you, Dr. Anand. Thank you for being the guest for the day. And now over to you. Please proceed with your presentation.
Very good morning, and hope I'll able to keep up to your expectations, and the presentation will be good. Okay, I'll try my level best.
Tell all the audience that the session is live on YouTube and as well as on the Facebook. You can please start with the presentation.
Yeah. Can you see the screen, please? Can you see my screen?
Yeah.
Okay. Okay, fine. I'm audible and the screen is also being seen clearly. Shall I start?
Yeah, please.
Yeah. Thank you, Megha. Thank you for this warm words. And I don't know how to explain for the Megha to such a all welcoming, and also the dean of your institution giving me an opportunity. And students, welcome. My teaching and the presentation styles are a bit different, a little more of a fun rather than of a subject. So hope you'll all enjoy it, and take home messages will be clear. Okay. Okay, this is the thought of the day for today. And this is my workplace, our university. Before we proceed, we will have a small tour of our university. Okay, thank you. Okay, this is myself. There are small contributions which I did for the our faculty and for our dentistry for the oral pathology. This is my presentations in 2019, and this is my presentation in 2020 for SRM University and for SEGI University. And in 2021, I presented for the SDM Dharwad University. 22, thank you. Started with you, and tomorrow also I have a session with Punjab. Okay. This is my contributions towards the oral pathology and also with an pediatric. I got an opportunity to contribute 5 chapters for the McDonald's textbook. Okay. Yeah, I think the image says everything. I don't need to give an explanatory. The Guru Dronacharya is explaining his. Can audible? Is that all clear?
Yeah, you're audible.
Yeah. So he's giving his the best student Arjuna, and that best student is our Meghanand. The other 3 you can standing there is me, Sangvesh, and my other juniors standing there. Okay, and I was fortunate that Dronacharya Arjuna had one teacher within the Dronacharya, and I was very fortunate. I had 4 teachers. I have 4 Dronacharyas. This is Dr. Vaniki, Srinivas Vaniki, and sir is a dean of PMM Dental College, Bagalkot, where I did my UG and PG. He was the first person who put a seed of oral pathology in me, which I hated a lot, as many of you do it. Somehow, but wonderful, amazing teacher. There's an fantastic teacher. And second, my Dronacharya is Dr. Rajiv Desai. Sir is an HOD of Nair Dental College, Mumbai. He's a postgraduate teacher and an extremely fantastic oral pathologist. And I was blessed to have, I was the first his first postgraduate student. So this is Dr. Rajiv Desai and my second Dronacharya. Third Dronacharya is Dr. Rekha V. Kumar. She is a professor and head in Kidwai Oncology, Bangalore. She is my PhD guide. She extremely good. Must be around. You can go to the Google Explorer. She must have around 20,000 plus citation. Extremely amazing teacher. Last thing, this is a very renowned oral pathologist globally. He did not teach me oral pathology. I was an Ekalavya of his Gurukul. I learned everything standing much away from things. He is an excellent. So we could able to learn more things. That's the message for the youngsters. What I want to give for this is, it's not necessary that it should be a sunrise should fall directly on the leaf to produce an chloroform. You need to do it, and you need to extract from a teacher. No teacher will make you to drink water. He can only take you to the tank. Rest is up to you. How you are going to do that? Okay. That's I was really fortunate to have this 4 Dronacharyas, and I am blessed. And this is our Viru and Jai. Our can you identify him? He had a lot of hair then. Now I think if people don't identify him, he looks more of Mahatma Gandhi, but it's not. He was not same. He was the one. Or you can see him on the left side image. Meghanand and me in 2001. So we know each other from more than 2 decades. So oral pathology language, more than 20 years. Okay. The right side image is our 3 batchmates. That was the first batch of our 3 batch students in Bagalkot as a oral pathology. Meghanand was an government student. Me and Sangvesh were management quota. We both were localates. So you can put it as anything you like it. That's up to your imagination. 3 Idiots, Trimurti, whatever. We were in a good gel and thick, and that 20 years after 20 years also, the gelling is same what we had then in 2001. Okay. And this presentation for today, my target audience will be you all, the budding oral pathologist or budding dentist, especially this year 3 and interns. Year 3 are the one who just hate the subject, who also hate the oral pathology teachers. And intern is the one who felt that, oh my God, I am one step ahead of this. I don't need to see any more, what is this, slides or something like that, which I don't understand. Yeah, that's a true fact. I understand. When I was student, it was, I also understood only two things, pink and blue color, which you all do right now. Okay, so I will try to keep it as simple. Okay, so today's topic will be for the odontogenic tumor. Yeah, you read it very good. Both the slides are correct slides. Yes, I'm not here to teach you odontogenic tumor. Yes, what Sanjay just said is correct. That you already have in great teachers. Okay, you have a big guns in the university of Tirthankar University. You have Mega, you have your other junior faculties. They have definitely taught you, and I am sure that you have learned and have enriched with the oral pathology under the training of your beloved teachers. Okay, what I will try to do. Okay, can you read this on the left side? Exactly, oral pathology and odontogenic tumors, everything is same. I can read this, but I don't understand. Simple one. Same thing, if I start adding up, yesterday I was discussing with Mega, he said, recent trend does not, please don't make a buffet so that student will start getting into what they don't understand. Make it as a thali where everything is available in a little quantity and what they should be knowing. Because target audience were very clear with an interns and year 3 students. I don't want to, definitely you all can read this, but none of you understood what is that. It all says good morning in a different languages. The same thing you can put on the right side. The mutations happening with this A, B, C, D, E, F, G, H, I, I, J, K, L, M, N, O, P, Q, R, S. Same thing, exactly. You just have to split into 3-4 lines and make into a word are the genes which has been expressed. If the development of the tooth has a 300 genes, then pathology will have more than that. So no point. I will not discuss for the today's class what happens with the IIC, what happens with the pathogenesis of that, all the things we have learned and what is there in the textbook. We are not going to dig it again and make you boring sessions. We'll make it as a simple one. As I said, your stomach should be full and you should also enjoy the food. Okay, so we'll have a small quantity everything and in a thali. Okay, get ready. I'll try to keep it very simple. Now you understood what is that. You can read both and you can understand also. This is how we will go for the today's session. Tell me how many of you like this to see then and now. Then also you did not like it. And how many of you really felt that in the year 3, in the year 1 you passed out, ये कब देखूंगा यार मैं, इससे क्या मतलब है, क्यों मेघानंद हमारा पीछे पड़ा हुआ है? How many of you felt? Everybody. I know that because I used to curse Vanki sir the same way how we used to do that. If without it is of use, we are not going to teach you. As a student, I also felt that. Now, when I became teacher, I understood, okay, it's not that. So each of the slide which has been shown to you will be helpful when they become into pathology. So now, whatever you have learned from your bud stage to the advanced bell stages, all those teachers, including your outer enamel epithelium, inner enamel epithelium, stereo reticulum, dental follicle, papilla, everything is important. One or others are being involved in the pathology and becoming into an odontogenic tumor. Okay, say, taking simple. This is our territory. Our territory is a limited one. Okay, our territory starts with the jaw and ends with the jaws. Have you ever heard something like somebody had an ameloblastoma in the lung, somebody had an ameloblastoma in his lower limb, somebody had an ameloblastoma in the hand? So we can have a teratoma. I'm not talking about teratoma, look-alike tissues, which is something like it may look like a tooth-like appearances has been found in the kidney. All those things we read in the newspaper, but Are we really, have we gone through any time that we have undergone an ameloblastic surgery for in the lung? No. Our territory is very short and very sweet one. It belongs to the jaw, and it should, the formation of the tooth to the pathology of the odontogenic tumors should start and end with our odontogenic apparatus. Both simple. Any rest for that matter, anything. Maybe it's a cell rest of malaise or serous series, or it may be a follicle, it may be reduced enamel epithelium. Any part of a dental organ can be your pathology. So when you write for exam, just keep in your mind in year 1, add up 1. It will be one of them will be definitely should be in there. Be careful, don't tell to Meganan. And we oral pathologists are very good at one thing. I accept for this. Okay, I don't know, Dean sir must be a clinical subject, so he will be definitely accepting with me. We always are very good and excellent in confusing the students and also clinicians. And if you want more about to know about oral pathologist, meet oral surgeon and oral radiologist, oral medicine people. They will give a very good example of an oral pathologist. They are very good at classification, reclassification, then again classify. 2001, we joined post-graduation. Then it was called as an OKC. Kya matlab tha pata nahi. Then they started a huge, no, it's not in cyst, it should be a tumor. Around 200-300 papers publication हुआ. जब तक हम लोग graduate हो गए थे, वो tumor बन गया. सिस्ट से ट्यूमर बन गया. सो रैपिडली इन 5 साल में ट्यूमर बन गया. हम लोग रट्टा मार के 2004 के एग्जाम की तैयारी कर रहे ट्यूमर के लिए. जिसे ग्रेजुएट हो गए, हम लोग बाहर आ गए, पास हो गए हम लोग. देन लेटर देन दे सेड नहीं ट्यूमर नहीं है, इट शुड बी अ सिस्ट. So suddenly it become from go back to the cyst. Okay, so don't worry if you are reading it as a cyst today. When you graduate, it might be a tumor or it might be something else. We are good at it. We'll change something. We'll do something else this time. Don't worry. And this time we will use some other techniques and we'll keep you into surprise. And this next one, very important, leukoplakia, OSMF, oral potential malignant condition. Condition or lesion हुआ करता था. Then suddenly we thought terminology सुनने में अच्छा नहीं था हम लोगों को. Then we thought okay, we'll make it as an lesion condition. बहुत सारे lesion है, condition है, सब थोड़ा सा इसका condition change करेंगे, English use करेंगे हम लोग. Then we made it as an OPMD. Okay, potentially malignant disorder. So थोड़ा English में बदलाव आया. ये भी हम लोगों को थोड़ा सा 5-6 साल में बोर हो गए हम लोग terminology जितना. So 2019 में we have changed it as something called as PPOEL. So बोले में इतना something ऐसा लगना चाहिए TOEFL लिख रहे हैं हम लोग. So we just made it into a little more of an PPOEL. So before this graduate year 3 students who are writing the exam now, when they become into writing for the NEET exam, maybe this may come into textbook. Fortunately, it has been not accepted. The terminology has not been accepted still by WHO. Don't worry, we will try for that also very soon. This one, the recent one, so you all must have known, and your teachers would have already discussed with that, so I will not go with that. You learned for that. Okay, so these are epithelial origins, mixed origins, and it can be of mesenchymal origin. My teacher, Rajesh sir, used to always say one thing: oral pathology is easy only when you make it into an word to word, you understand that. Okay, you read with an title of that, why they have been sub-classified into 3. Okay, they have been classified into sub-3, that is because of this. Based on the odontogenic tissue they mimic. This person is not Saif Ali Khan, that's not an Ajay Devgan, and he is not Virat Kohli, and he is also not an Mr. Bachchan Saab. They look like that. This is an what is this? Dental organ, and this is a pathology. They look or mimic of their parent tissue or their odontogenic organ. So, based on that, they classified into A, B, and C. Okay, fine. Very important. I didn't take the 2017 WHO classification. What is this definition? It's quite old and maybe around 40-50-year-old definition of amyloblastoma. 2017, if you nobody writes in the exam. So what is important for exam? I thought this is important for your exams, so you can read and understand this better. My teacher, I was just telling you, my teacher said, Rajesh Desai sir is always used to say this line. If you by this, you'll never understand, and nor you're going to remember it for lifetime. Split each word and understand the meaning of that. Then it becomes easy for you. Then you will never forget. This is how it can be unicentric, having in the single center, non-functional, not of any particular purpose. Same way, just split into the multiple words with their meaning, then it becomes, definition becomes very easy. How many of you know the definition of OSMF according to the Schaefer? Try this technique. It's easy. Okay. I know that you must be knowing this. What is the etiology? It should come easily. It should come. We have an our phone. Easiest one, like how we used to write in the pharmacology. What are the side effects of the drug? Nausea, vomiting, diarrhea. Simple line. Odontogenic tumors. These things you must know. Keep it in your mind. I know this. This is what we have to write. Now, what is if there's the same thing? All this thing has been written in the textbook. Like you need to have something better. That's what Mega was saying. Put a new, recent, innovative, or recent things which they can write or understand. Okay. Correct. Whatever you have learned, all these things are correct for if you give an answer. Okay. But if you answer something like that, you will be, the teacher will be thinking, इतना ही है तेरा, इस साल तो पास नहीं होगा, 6 महीने क्या बाद आना. Same lines, huh? These are the same lines I used to hear, so very familiar. Okay. Simple thing. How it is, we make it into more complicated. Okay, simple. If you ask a year 3 student, what is this lesion? Okay, start from here. What is this? Answer should be very simple, one line, and the true answer will come by an undergraduate, might be an year 3 or an intern will talk about the correct one. So if you take it as a video student, what is that? Simple, one line answer. It's a cow. And answer is correct. But we have to do 3 years post-graduation, no? So we need to learn more, we need to acquire more knowledge. So what we do, we try to learn more about that cow. Okay, say, every student will say, this may be a cow. मैं मालूम है वो cow ही है. Hey, नहीं बोलेंगे हम लोग. This may be a cow. Or something like an pigmented buffalo or hypertrophied goat. Simple line, we know that what is that, but we will not put it in a simple one. Or it may be an elephant which has been atrophy. Okay, this is the difference between a PG and the PhD, MDS. Now imagine what can be the answer from the PhD. So let us not discuss about that. Okay. Okay. How we can write? This is the recent one. If you read for the WHO books, they say the etiology may be something like this. It is a trigger or a stimulus for a neoplastic transformation of an residuals of unknown. You don't know how it is going to happen. Everybody is known to get for a tumor. Everybody is known to get for the chances of getting into an cancer. But only thing is, it is already pre-programmed. It should express or it is not going to express. So individually is likely to result of an alterations or mutations in a genetic material of cells that are embryologically pre-programmed for the tooth development. It should have been already for the development of a tooth. It should become a canine or a central incisor or a premolar. But unfortunately, it becomes an odontoma. It can, something can change for that. So harbor oncogenic mutations predominantly of a BRAF and SMO. So this is, I think, in the next level of your writing, you can add up this. You can fetch a little more marks for undergraduates. Okay, so continue. Individually, the types of ameloblastoma can be of three types. What is this? Conventional, which is in multicystic, unicystic, and peripheral. Just to confine, I will be sticking to the one of them, multicystic, conventional solid or multicystic only. Unicystic and peripheral, it's a lot of discussion, and we don't have so much of time to elaborate for that. So I have skipped that. Okay. Simple one, it is rare in children and with the mandibular third molars, very commonly even with the posterior regions, asymptomatic, leads to the facial asymmetry. This is around 4 to 5 centimeters, has a cortical expansion. The cortical becomes expanded. Because of this cortical expanded, this becomes more thinner, and it becomes into an, when you feel, you have a tactile sensations, it gives an oil can bottoming, or it is an eggshell cracking sound. So every time, next time when you make a dish from an egg, think of ameloblastoma. You'll never forget. This is a clinical feature of ameloblastoma. Clinically, when I palpate, it appears something like this. Okay, these are the clinical features. It might be a smaller one because it's asymptomatic. There are the features which is maybe of a 14 inches, 15 inches. This we can see on the right side of the image. This is asymptomatic. Most of the people will not symptoms, and as they don't have symptoms, they don't respond to the treatment for that. They don't come to the treatment. Now, differential diagnosis and five we should have. Clinically, they appear as something like maybe CGCG, but ameloblastomas are more common with the anterior. CGCGs are more common with the ameloblastomas are more common with the posteriors, and CGCGs are more common with the anterior one. So it can be an OKC, which can be an anterior posterior. We don't know how it expands. Okay. Now there is a quite interesting part. Increased frequency in the ameloblastomas are more common in the anterior part of the jaw in the African community. Now the dental follicle is different, or expression is different. What is that? A, B, C, D, E, F, G, H, I, J, K genes are different. We don't know. Dentists are rarer in South African blacks, whereas ameloblastomas are more common in the blacks, anterior parts. OKC is far less prevalent in the black population. No, we don't know why exactly it happens, and what is the reason for that, we don't know. Epithelium clusters are less common. Okay. What is the imaging shows for that? Imaging shows it's an multilocular or sobable appearances. I said, you always should remember something, whatever it has been said, correlate with that. Now, if you say that is a sobable appearances or multilocular, if you see the right side image, definitely you're not going to remember for that. Take the image of the left side. Keep in your mind, sobable means something like this, which would have played from the when we were just 2-year-old till now. The same sobable, but we get confused to write in the exams. So sobable appearance is something like this. Okay. What is the commonest differential diagnosis for this? It can be OKC, ameloblastoma, dentigenesis, CEOC, COT, anything. Okay, it can be anything because the third molar and it is an unilocular, a big expanded. Anything, maybe it might not be an classical dentigenesis because the expansion is big, but oral pathology is very, very unique thing, something we don't know. There can be an expansion of an ameloblastoma for a bigger one. We don't know what is the exact size to be called as an OKC, or what it should be called for that. So we can just go on debating, saying that it's a resorption is seen, so that might be an more aggressive. Here on the right side, we don't find any teeth, so teeth have been lost. So anything, but just to put it as on the easier way, ameloblastomas are more common with the posterior part and with the impacted tooth. Okay. Imaging. This is according to the DCNA of 2020. Dentigenesis shows more of an radiolucency, where ameloblastoma not necessarily pericorneal radiolucencies. Mineralizations is seen with the COT and COC. So I can differentiate between the DC, ameloblastoma, COC, and a COT. Actually, it is, we don't accept the oral pathology that dentigenesis giving rise to ameloblastoma, dentigenesis giving rise to what is this secondary later part giving for the tumor, OKC, all those things. But we can see publications even in the 2019, 2020 also. Long back in the textbook by the Share, it has been mentioned very clearly. ऐसा कुछ नहीं होती है. He has given the 3 reasons why it cannot be. Okay, please read that. No, not necessary to explain for this. Okay. Okay, amazing. MRI and CT. I don't know how many patients can really afford for that, but for the better treatment, we should always for an MRI to get an cystic lining or a space for the dentigerous cyst. CBCT. Now it has become very common. I think most of the universities do have the CBCT in their oral medicine. So now it has become an like how once upon a time when OPG was an high end of an radiology. Now I think CBCT has become a common one to have in the each universities. Okay. Okay. And same to same. If you have watched this movie, talking is same to same used to happen when I used to see the slide under the microscope. Only 2 colors are observed. One is pink and one is blue. Then rest all is on fine. ये बच्चा मुझे बहुत याद आता है तारे जमीन पर, especially Viva also. I start seeing the stars in the day also. Okay, so
आप बात कर लेना एक बार
किनसे
मीडिया वालों से या कैसे करेंगे वो.
Okay, the oral pathology is an that's very important to read the preface of a textbook. Very clearly it is mentioned in a book. Oral pathology is a highly visual subject. You cannot mug it up, or you must see to remember it. Okay, so the oral pathology is a highly visual subject. Try to see, observe, then correlate it with the clinical or with the, try to remember it, easier one. The classical example is this. What mind knows will read the slide. If you do not know the features of an dentigerous cyst or an ameloblastoma and you want to see in the microscope, you will never understand. This is how it happens with, if you want to see without the knowledge of an theoretical knowledge, if you go and see the, if I don't know what are the features seen in the ameloblastoma, this is what happens. The lady sees it as a dustbin, a child sees it as a monster, the other child sees it as a burger, and he's thinking, maybe he's a postgraduate student, has come with the family and is struggling. It's very easy. So find with an odontogenic epithelium, there is a criteria for that. Okay, Anand and Meghanand criteria. How is that? If you remember, the cells are usually long columnar. You remember long columnar cells? Okay. Now it has a hyperchromatic nucleus. Point number 2. Okay. Now this hyperchromatic nucleus always been away from the basement membrane. Easy to remember. Just imagine the left side image. You put a lime in a jar and put a water for that. ये lime अपने आप ऊपर आएगा. So the same way, when the matrix has been added, enamel matrix has been added for the, there is an increase in the secretion of the enamel matrix with the cell, nucleus अपने आप ऊपर जाएगी, ये एक खाली दिखेगी नीचे वाला. So the criteria to identify an odontogenic epithelium are 3: long columnar epithelium, okay, then hyperchromatic nucleus, the cell is away from the basement. So long columnar, अपना साफ तो दिख ही रहे, long columnar, left side, because away from the basement membrane, put water, it's coming out. So Anand and Meghanand the criteria. Please don't write in the exam. Huh? In exams, you can write it as a Vickers and Gorlin's criteria. To remember, you can take it any name, but when you write in the exam, to take care that you write it as a Vickers and Gorlin's criteria only. How to remember? It's very common and very easy to remember. Ameloblastoma has an long palisading-like appearances. Yes, simple. The sticks-like appearances arranged in one line. So palisading appearances. Amitabh साहब को आपने अभी देखा है, तो long columnar, all the cells are long columnar, and the nucleus has been away from that, and the basement membrane has been, the basal areas vacuolated, 3 areas. The center one is star-like appearances. इससे बड़ा star कौन सा है? Amitabh. So remember. So Amyloblastoma cells to remember. The only two things you need to remember: Lyme and Amitabh Bachchan. So you'll easy to remember how to write for your description of an histopathology in your exams. A Kamalasan Dashavatam. If he can, one person can play an 10 roles, can come into an 10 images, 10 can make into an 10 different things. The same way it's amyloblastoma. It's a simple one. Now it becomes into an Chata avatar, only 6 lesions. Maybe in another couple of years we'll make it 10. Don't worry. We will also make the amyloblastoma Dashavataram. So till then, you please do learn about this 6. Okay, 6 variants of that. Now, what are those 6 variants? That's the difficulty appears now. जब भी amyloblastoma अमिता साहब तो है नहीं, हर बार जब अंदर आएंगे रिश्ते में तुम्हारा पाप लगता हूँ, नाम है शहंशाह विजय दीनानाथ चौहान. नहीं तो बोलेंगे तो है नहीं, हमें ही पढ़ना पड़ेगा. You need to sit and learn for that. And these are the 6 histological types of our amyloblastoma: follicular, flexiform, basal, acanthomatous, granular, desmoplastic. Now 2 I have made it as an highlighted, so-called what is this, aggressive. Desmoplastic variants are more bigger, or chances of aggressiveness is more higher. I don't know. There are a lot of discussions in the literature, but सच्चा क्या है मुझे नहीं मालूम. Okay, is it सच है, सच्चा झूठा, we don't know. We'll put for that. According to the renowned textbook Somes and Sotham, he says there are only 2 types of ameloblastomas, and that is follicular and the flexiform. And also this combination of these 2 can exist in the same case. Okay. The second very renowned textbook, Scuba and Riggsy. Now he says separation of amyloblastoma into a various microscopic group described is essentially an academic exercise because there appears to be no correlation between a clinical behavior and their microscopic patterns. But he mentions there, microscopically, it can be desmoplastic, follicular, flexiform, granular, basiloid, all forms he accepts. So he has written them. But underline, I don't know. You all remember this? We want to keep it simple. Amir Khan also tried. कोई और रास्ता है? So don't try. Don't try to write all those things in the exams. Don't try to make it things simple. Don't try to explain what is machine in a simple language. Complicated rako. You must know all the 6 variants. Okay. So learn for all the 6 variants. Know them. And aggressive, non-aggressive, for undergraduates, it's not a very highly important for that. So you learn for your academic knowledge. There are 6 variants, and what else is? Because in the textbook it says granular and desmoplastic are different variant of or aggressive variants of amyloblastoma. Also try to read, and especially I insist interns to do this. This will help you for your future. Really high regards to this thing. What is this? SAP, and this is and Rexy and Scuba, and this is Max and Stern. These are in surgeons. They have mentioned this. The third book. If you get somewhere, it's in the library. Just go through the amyloblastoma. What do we learn? The concepts of ameloblastomas are quite different in this. Okay, especially the unicystic and the unicystic variants. So please do read them. And the Somes and Sotham, what I just gave an example of one of that. So I took an example, whatever I've taken from this is from the one is in Rexy and Scuba, and one is from the Somes and Sotham. The second and the 4th textbook, I have given an example for that. So read, please do read and increase your knowledge. And it's always good. If you know, there's no harm to learn better and have a better knowledge. Okay. Ameloblastic carcinoma. The right side is an ameloblastoma and left side. You can see the differences between the cell types. This looks more of an our what is this hero, and that becomes into our more of villain. I don't want to take anybody's name. You can imagine of that. Okay. Itna common hai. In my 20 to 20 years of experience, I have seen one. Okay, so we'll not discuss. Ameloblastoma fibroma. Now here, whatever you learned in from year one will come one by one into action. This is because of the overproduction of our basal cells, origin differentiation. Exact cause we don't know. More common with both what is this? Males and females are equally affected. More commonly with the posterior of the mandible, associated maybe and may or may not be associated with an impacted. It can be unilocular or it can be multilocular, or it can be not associated with the tooth also. You can see the right side image. It doesn't look like an odontogenic origin. Histology. Histology is quite interesting here. This is the one which is the left side is the year one image, what you learned for a wet stage. Looks very familiar of an enamel organ. Only differences between this is because it has become into pathology. You can find a difference here is, see the blue color arrow as ameloblastoma, no confusion with that. Looks like ameloblastoma island, but we should not confuse the ameloblastoma fibroma for the in the exam slides. So look for a connective tissue. The blue arrow, see the blue arrow on the right side. See the connective tissue is different from here to there, and both the connective tissue in the left side and the right side, blue arrows, the connective tissue is different. See the yellow color just adjacent to the island. Adjacent to the island, there is an hyalinization. There is a small paint like a pink color paint like appearances. That's fibroma, and that's an ameloblastoma on the left side. That's how you have to look for that. This is if your mind knows, your eyes sees in your slide. That's more easier for you. Okay. So next time when you go for the seeing the slide, read what has been taught in the class. What are the high points which I should know? Then try to appreciate in the slide. ट्यूमर ऑफ 2/3 ऐसे कौन सी ट्यूमर है यार? मेघानंद ने कभी पढ़ा या नहीं था? ऐसे कोई नाम नहीं था ना ही क्लासिफिकेशन में, इसने इसे कुछ दिखा ही नहीं. ये कहाँ से आ गया? ट्यूमर ऑफ 2/3. ट्यूमर ऑफ 2/3 is an AOT. Why they call it as a tumor of a 2/3 is the 2/3 occurs in the second decade of the life. Most commonly, it's a 2/3 of the lesions occurs in the anterior maxilla. 2/3 of the lesions occurs in the female. Usually 2/3 of the cases are with the impacted tooth, and this is a 2/3 of them can be also occur with the what is this? The canine. Okay. Yes. Any year 3 student, can you please identify what is this? The arrow indicating. Now that is the origin, the source of origin for the 2/3 tumor or an AOT. Anybody? Okay. Outer enamel epithelium, inner enamel epithelium. The white is Amitabh Bachchan, superstar, star-like epithelium. Stellate reticulum, correct. Now, between the stellate reticulum and the inner enamel epithelium, a small line, flattened cells between them. So use the word. That's what I said. Between the word, between them. So intermediate, stratum intermedium. Okay, this can be the origin. Now again, as I told, like OKC, we also had this a lot of discussion. Fortunately, long back, it was before we joined into the much discussions. Before the exams, it got resolved. It did not have much difficulty for our exams. Before our exams, they said no, it's not an hematoma nor it's a tumor. Sorry, what is this? Not as a cyst. So we can put it as an what is this? Odontogenic tumor. So still it is existing as a tumor. So no more debate about the cyst or an hematoma. Okay. This also can be associated with or without the impacted tooth or associated with the teeth. The very important imaging part here is, you can see the yellow color line, the dentigerous cyst and AOT. How to differentiate radiologically a dentigerous cyst and an AOT? Usually the AOTs are, you can see this yellow color arrow. The lesion circumstances is being below the neck of the tumor, neck of the tooth, means below the CEJ. The integer cysts are usually at the neck of the tooth or a CEJ. This is below that one. Both the images you can appreciate for that. There can also be in small calcifications in aorta in some of the cases. Okay. Variants of that: extrafollicular, follicular, and peripheral. That's E1, E2, E3, E4, and peripheral and follicular. So follicular usually gets into confusion for the integer cyst, but as I said, it is. You can see that in the canine region, you can see that the demarcation for the CJ is very clear. That it has been gone below the neck of the tooth. Okay, one. Now these are the variants. Now again, follicular, extrafollicular, and peripheral. It does make any differences for that? We don't know. The study said recently 1,558 cases have been observed in and reported in 2019. There are no differences in the clinically if it is a follicular, extrafollicular, or intermediate, whatever the regions. They did not find any differences in the peripheral, follicular, or an extrafollicular types of an aorta. Read. Instructions are where there. Star. Read the instructions. Please identify the flowers, not the actors. And that's the histology of your aorta. More easy to remember. So next time to remember for the aorta, you can remember this image. Okay, how is this histology related to this? The left side is sunflower-like appearances, and the right side is an rosette-like appearances. What are those? Okay, we'll see. Convoluted structures, rosette-like appearances on the red color. Then the second one is a duck-like appearances, DS, sunflower-like appearances, and the SN, the cuboidal epithelial cells. So तीन तो मैंने आपको बता दिया. अब दो और ऐड करनी है, connective tissue, blood vessels, inflammatory cells. All the things you can add up for that. Okay, so easy to remember. Next time, remember two flowers on the sunflower and not the film actors. Remember the sunflower and the rose. The next one is CEOT. Was the first reported by J.J. Pindberg. So we also call it as Pindberg tumor. So कल मेघानंद ने नया कुछ disease का अगर he reports first time, then we can maybe in the future generation textbooks we might find मेघानंद tumor. Okay, hope to see that soon. Please मेरा नाम भी डाल देना यार. Okay, now CEOT is mimicking something resemblance with something. Yes, the etiology we don't know, but still the origin remains as an stratum intermedium. Regions more commonly with the mandible, nose expedations, but not with the aorta, because the aortas are more common with the youngsters, and this is with the 3rd to 5th decade. Bony heart swelling and eggshell. Even the bony heart swelling is seen with the aorta, but eggshells are not common with the aorta. So few lesions, clinical features overlap. So one person in the Judva will be very Hercules-like person. The other one will be a very mild. Okay, like me and Meghananda. He is of more Hercules of the thing. I am very mild person of the Judva. Okay, some looks humshackle radiologically also. Like COT also shows an honeycomb appearances, and it can show an soap bubble appearances. Now, there's no differences with that. No, it will. It is a different. There is some differences or some radiological differences also we find with the COT. They appear as an snow-driven appearances. Okay, you can see the left side image. It's a snow-driven appearances, and the right side you can see the image showing an OPG with an lesion with an snow-driven appearances. Histologically, they show amyloid like a material will show an apple green. Apple here is an eating apple, not your telephone. Okay, apple green appearances. They also shows something called an Lisgang. Now, what is Lisgang? You can see the image on the mountain. There is a layers has been shown over that. Seeing that, they mentioned it as an Lisgang ring-like appearances. So know what is that and try to understand look for the features. Now, dunya mutti mein, aapke haath mein. Now it's not something like the time in 2001. Meghananda and me used to go to an internet search for the cafes, and two speed. You have to put as a Google, look for a Google first. It will take in just 10 minutes just to open it. The Google pages to come in 5 to 10 minutes, and by the time you download an article, it will be 1.5 hours. In that 2-3 times, the person who is sitting in the cafe will switch off because he need customer to sit for longer time. Those days, okay. Just lighter moment. Don't take it as seriously. Not to blame any cafe person. Okay, please do articles, reads. Now, just now I said there is a calcification, CEOT, calcified epithelium odontogenic tumor. So this is there is cases which has been reported, CEOTs, without calcification. Do read. This will really help those interns, those who are suddenly become a doctors. Suddenly, internship means something like 1 year, officially no reading. Most of the reading should happen then. Please, interns, don't waste your time. Okay, this is a recent one, 2020. You'll find most new recognized new things have been happening with the own thing. So to come to the textbook, these lines will take another 8 to 10 years. Okay, so please do read. Squamous odontogenic tumors, SOT. Now here they appear as an unilocular triangle in the nature. Now how to remember them is, take an image over that. You'll remember more easily. Every word of the oral pathology cannot be parted. You should understand, correlate, kaun humse kale, kaun judwa hai. You try to correlate between them and ask the questions to your classmate. Asking question is very easy. Try it. Asking, because it's not necessary that you should know the answer. Ask question. Okay, try this. And the classical one, differential diagnosis. Okay, impacted teeth, given differential diagnosis. Impacted teeth, given differential diagnosis for dentiger assist, one more dentiger assist. No, it should be OKC, amyloidoblastoma, COT, then you should add on. Don't give an example of one more example. Differential diagnosis should not be differentiated from your way. Okay, it should be fall in the same path. It can be an OKC, AOT, BOC, LPO, then odontogenic Mixomas. Okay. Terminology पढ़ने में time लग जाती है. SOTLP, squamous odontogenic tumor like proliferations. Okay, these are phenomena which are seen with an odontogenic cyst, and similarly they appear as islands of an SOT, and this can be misinterpreted and treatment can be failure. So be very, very careful. Ek cheez I just wanted to share. This is something like we always do that when you go for a practice. If it is not in your cup of tea, please call the specialist. Usko बुलाएगा, then I have to pay for him. Usko bhi cut देना पड़ेगा. देना पड़ेगा. You always be a safer and play hard. It's good for both you and a patient. Always don't try to do whatever is taught in the dentistry. Do not have to try yourself. There are specialists for that. Please do call. Okay. Odontomas, 2 types. कैसे याद रखे? एक तो compound है, एक तो complex है. तो complex हर रोज दिखते हैं हम लोग. So what are the types of amyloidoblastoma? एक compound है, एक complex है. Okay, ये complex का जो बाहर compound रहती है उसका complex है, second part. How them they appear as an histologically, compound looks like a clear one, so like sunrise of our omelette. Okay, the complex one is egg burji. Histologically, it looks something like this. Easier one. I can have a demarcation for the compound and the complex easily. Okay, this is how they appear radiologically. Differential diagnosis. It's not easy, huh? I don't know. It is an tooth structure appearances, or it is an hematoma, or it's an what is this impacted tooth, or it is an supernumerary teeth. anything it can be. So I have done this before. It becomes महंगा पड़ सकता है. He has done this before 25 years back. So he tried to do it again in what is this, Chennai Express. महंगा पड़ा. So everything you don't need to do it by yourself. Call your expert. It's okay. It's always been safer. It's not only the part of your financial this thing. It is always the patient is a first. Patient is a god. So we should always treat him the best possible. So do not compromise there. If you don't know, it's okay. Never mind. Call somebody who knows it. Okay. पहले किया था यार मैंने, उसने भी किया था, मगर second time ने किया. What was the problem? You all know. Okay. Go ahead. Complex and compound, normal appearing matrix, enamel, pulp tissues, and the cementum. Odontogenic Mixomas. This can be arising from the dental follicle, dental papilla. These are usually asymptomatic, usually 20 to 30 years of age, and males and females are commonly affected. Can be associated or with an missing or an embedded teeth. Radiologically, they also appear as an 4 types. One is soap bubble appearances, or it is an honeycomb-like appearances, or ladder-like appearances, or it can be an Bhupati-like appearances, Mahesh Bhupati or Leander piece appearances. What is that? Correct. Tennis racket appearances. So, 4 हो सकता है. There is like soap bubble appearances, honeycomb appearances, step ladder appearances, or it can be an tennis racket appearances. This is how they appear as in soap bubble. Okay. Can you see the image which has been circled? Ladder-like appearances. So that is an step ladder-like appearances. Okay, breakpoint. Recently, OTT में देखा था इसको, Mahesh Bhupati and Leander case. Okay, so easy. So next time to remember histology, remember 2 things. एक तो CD था जो आपके डीन ने मेघानंद ने बना के रखा है आपके लिए. Your parents have made for you. 1. Second, it is an honeycomb, honey, sweet of the life. Then third one, it can be a Mahesh Bhupati and Leander case. So tennis racket appearances. Histology can be more easier now. Histology next time is more easier to write. Okay, cotton candy. इसमें थोड़ा सा वो ब्लैक कलर का डाल दीजिए ऊपर. कॉटन कैंडी, इमेजिन कॉटन कैंडी, उसके ऊपर मैं सीसम सीड्स ब्लैक कलर का डालूंगा उसके ऊपर. कैसे लगेगी अगर मैं इमेजिन नाउ देयर इज अ कैंडी एंड ओवर दैट सीसम सीड्स हैज बीन एडेड. So it appears as a small dot-like appearances on that cotton candy. Same to same it will appear for the odontogenic myxoma. So next time, odontogenic myxoma histopathology, candy and sesame seeds. Please don't write the same thing in the exams. This happened with us. I always used to give to make it remember something like this. मैंने बोला था बच्चे को देखो जाइंट सेल कैसे रिमेम्बर, हाउ टू रिमेम्बर. कीप एज आनंद. मे बी तुम लोगों को जाइंट से दिखता हूँ, मन में तुम लोग भी गाली देते होंगे, तो इससे अच्छा नाम से लिख दो. In exam he wrote CGCG commonly shows Anand cells. Don't write cotton candy and sesame seeds. Okay, connect tissues with an nucleus-like appearances. These are odontogenic myxoma. Naya kya hai? What is new? This is not there in your textbooks. Search today, because if you have not opened your textbooks, आज कर दीजिएगा. This first case was reported in 2014. Looks like a primitive organ of a developing tooth, like a tooth developing of the tooth organ. So they called it as a primordial odontogenic tumor. बराबर, correct सुना आपने. ऐसे कुछ ये नहीं है, but till now in English literature there are about 11 cases has been reported until 20. 4 साल पहले 11 था. Maybe I did not find. यहाँ आने से पहले भी मैंने ट्राई करके आया हूँ. Maybe there may be some other languages there might be reported one, but as on till 2018 it was 11 cases reported for the primordial odontogenic tumor. So maybe next edition of Neville or our Schaefer we might find something like this. Okay, how does it appear? Clinically, because radiologically, it appeared as radiolucency. Now, it is not unilocular, clear-cut unilocular. Okay, and there is a resorption of a bone or what is this, tooth there. A lot of resorption happening. Now, the radiolucency, just now I was talking about the AOT and dentition assist. So I don't know, that's a amyloblastoma or like something like that. See the right side. This is now, should I confuse this for the fibroma? Lesion is not in the center, it is in the periphery. You can see those classical Amitabh Bachchan and what is this, hyperchromatic nuclei, and also within the lemon has been added, the water has been pushed, the line to the upper part of the jaw. Same, all the criteria of Vickers and Gorlin's criteria has been seen there. Primitive ectomesenchymal connective tissue, the lesion something like this, and over this epithelium there is an superstar. Amitabh Bachchan again coming into an stellate reticulum like appearances. This is a radiology because we don't know. बाकी लोगों ने इसमें publication में ये नहीं डाला था, क्या था, radiology और histopathology नहीं था. I could find one with one person has put this. So might be this is a new odontogenic origin. Maybe in 2027 we might find somewhere else in the to read more frequently. Okay. So to come to the last part of that, we don't know. So there is still very limited information of how pathogenesis of the odontogenic happens. It might be a single gene or in a single mutatic happens with small gene panels or the advances in the molecular, whatever has been got like immunohistochemistry, whatever we have, the advanced technologies, though it has been tremendous technologies has been improved to identify the DNA sequences in the past 10 years. Still, we are not being able to precisely say what is the origin of an ameloblastoma, what is the origin for how it happens, why the cell rest is with me also, with you also. The cell rest is the impacted tooth can be with the what is this, less than 20 years. Many will be having an impacted tooth. उनको क्यों नहीं हुआ, बाकी लोगों को क्यों होती है, जिसका आंसर अभी तक नहीं मिला. Some portion we are being able to answer. Some genetically it might be I don't know how to answer for that. So precisely this is I took from the recent article 2021. So even they did not give any classical, but they said SOH and BR, BF are involved and MARKs are involved. So अगर मैं स्टार्ट बोलूँगा, मैं ऐसे जीन का नाम बोलते जाऊंगा, आपको लगे कि मैं फ्रेंच बात कर रहा हूँ. सडनली ना हिंदी था ना ही इंग्लिश था. So it's better I'll stop it here. So that's where we have, because हमारे पास इतना समय नहीं है. We'll end up this. What is your take home message? अभी अभी तक क्या पढ़ा और very simple line. I said ameloblastomas are more common with the posterior regions of the mandible and impacted teeth. ये tissues, whatever the number of publications we have seen, according to that we are talking about this. It can happen in the anterior region also, like in the Africans have a very commonly with the ameloblastomas are more common with the anteriors. So very simple one is, do not think that it will be something like this sure shot until you get an histopathology. So all the tissues, do not put it into, rather than sending it, put it into the pairs, you put it into the oral pathologist, give him, ask for the what is the diagnosis for that. So do remember, you read textbooks. Textbook has been mentioning ameloblastomas are seen with the posterior part of the mandible, more common in the mandible than the maxilla. आपने पढ़ा है, disease is, no, I have not read. So there are some common lesions, maxillary में हो सकती है, mandibular में हो सकती है, मगर disease को नहीं मालूम. Okay, so if it is that is the reason, if it is a follicle is the one is happening or the remnant is happening, then is that any different with the remnants with the Africans with the other part of the world? We don't know. Okay, so wherever it is required, please do call an oral pathologist, oral medicine person, oral surgeon to your clinic. Take his opinion before doing something. Okay. And the very important one, as a clinician, you can suspect a diagnosis. Please don't expect it from us. Okay. Key work and the cooperation is an classical sign for the success. Always do remember, for a successful practice to learn, go ahead. Oral medicine and oral surgeons are the good friends of oral pathologists. ईशान बनने का जरूरत नहीं है. If you are already facing issues with ईशान of learning oral pathology, ask your teacher. इसमें कोई डरने की बात नहीं है. एक बार दूसरा बार पूछ लो, पूछने में कोई हर्ज नहीं है. अगर एक बार में समझ में नहीं आई, the amyloidostomy cell started dancing on the slide or moving on the slide, it's okay. It started moving on the walls also is okay. Ask your teacher. Ask your teacher who is very close to you. It's not necessary. If you go to Meghand, I don't think that he will say no for this. Any of your professors or of your lecturers will not say no for that. Please do ask your teachers. Don't keep ununderstood things or something which has not been understood. Keep it and make it a small pinching like happening in the in your brain. Please ask it and resolve the things. Because very interesting a part of an oral pathology. This one, if you are very well versed with the reading with an Schaefer, especially the Schaefer which was an older edition, 93 edition, the orange color book. And then advice for all the interns who are there, if you buy, if you find those, what is this, orange color, little darker orange color, what is this, oral pathology textbook, अगर आपको ओल्ड बुक्स में स्टॉल में मिलेगी, रद्दी के शॉप में मिलेगी, किसी के अगर लाइब्रेरी में एक पीस पड़ा हुआ, उसको जेरॉक्स कर लीजिएगा. दैट्स अ बाइबल फॉर लाइफ टाइम. आपके हमारे जब तक हम लोग, वैसे भी वो ब्लैक एंड व्हाइट है, तो जेरॉक्स भी कर लेंगे आप लोग, इससे कोई डिफरेंस नहीं पड़ेगी. इट्स एन वंडरफुल बुक. Now only difference is because it's written by UK person, English is very beautiful in that. Like our Amitabh Sahab, जैसे अमिताभ साहब बोलते थे, same to same. I can walk English, I can talk English, I can eat English. Same to same lines happen with the oral pathology. It's very easy because lesions are more common with the males, but can also be seen with the females. Lesions are usually seen with the 3rd to 9th decade of the life, but can also be seen with the children. Most commonly associated with the posterior part of the mandible, but any part of the quadrant of the jaw can be, lesion can be seen. Usually these are asymptomatic unless it is secondarily infected. Patient may report to you with a pain little later. Usually that does not recur. Sometimes it may recur, so follow-up is required. Now इसमें take home मेरे को समझ में नहीं आई, ये बच्चे में होती है ज्यादा, बड़ों में होती है, it happens in female, सब कुछ बोला उसने. So it's something और अमिताभ साहब का classical one. Okay. Eat healthy and stay indoor. Take care. अभी pandemic खत्म नहीं हुआ, cases कम हो गए. Take care. Bye. Thank you. And this is my contact number. फिर भी दिल है हिंदुस्तानी. So still I retaining the Indian number for my WhatsApp. So you can WhatsApp me. I'm not very good at media, what is it, social media. Don't feel bad if I don't respond to you within 1-2 hours or something like that. I might take time, but I'll definitely do it. Okay. Now midterm exams are going on in our universities. This is our classroom, so nobody is there. I'm free. Just finished the exams and the students have left the university. Okay.
An excellent presentation by Dr. Anand. I think all the students have enjoyed it and they have really liked what you told, because like, oh, this is totally out of the routine thing, not out of the book. I think simplifying oral pathology is what Anand is best at. I think I guess like all the students enjoyed the session.
Hope so.
Any questions
Okay.
from the students or anybody in the audience?
Yes, sir.
Yeah,
please.
Yeah, Diksha.
No, sir, I haven't.
That's okay. Never mind. You can type it. I've shown the number for you. You can just write it there. Anything, please do not hesitate for that. Okay. Anybody else?
Anybody else?
Anybody else have questions? Any queries?
Okay, I guess there are no questions. I would like to give the mic to Dr. Geetanshu. She's a professor in our department. She would like to do the vote of thanks. Over to you, Geetanshu.
Thank you, sir. First and foremost, I would like to thank our esteemed speaker for the day, Dr. Anand S. Tenganamani, for such an insightful, informative, and innovative session. Sir, I have taught odontogenic tumors so many times. I have attended so many classes, but I think this was the best lecture of my life that I have heard today.
Hope so. People would grasp it.
We are also very grateful to Dr. Manish Goyal, sir, Principal, Dental College, for his valuable guidance. Next, I would like to thank Dr. Meghanand Nayak for his vision and commitment to making this session successful. My heartfelt acknowledgement to Dr. Shilpa and Dr. Jyoti for their time and effort in putting this session together. I thank all the postgraduate students of Department of Oral Pathology and Microbiology for their ever zealous spirit towards conducting the session. Last but not the least, I would like to express my humble gratitude to all our BDS students present here, especially the third BDS. And since this event was conducted under the flagship of Institutions Innovation Council, I extend gratitude and heartfelt thanks to Dr. Manjula Jain. Madam is the president of IIC TMU and also the Associate Dean Academics of TMU. Thank you, everybody.
Thank you all. As my special thanks to Dean sir who gave an opportunity for this.
Thank you all for attending the session.
Okay, thanks Mega. Thank you. Anything else? Any day? Let me know. We'll catch up.
Sure. Thank you so much.